When we initially came, we started with Medina location, and we had anticipated that would be our center of what would be going on, and it turns out we have more Wadsworth clients than we do in Medina right now.
Let's take it from the top. What does LCADA Way do here in Wadsworth?
Okay, we have a variety of services. It all starts with calling the intake, the 330-952-1546. You talk to an intake person. If you're uninsured, they'll hook you up with a Medicaid enrollment specialist or look at what you have. If you don't have insured or are underinsured, we can work with that. So it starts with, to make sure that it's the appropriate client and that the issue or the main focus of the problem that they're having is drug or alcohol related. Now, people who come in have a variety of other issues that are problems between mental health and lack of medical attention, dental work, and that sort of thing. And we'll hook people up with those services, either through our agency or through referral. So once that we've established, this is a drug or alcohol problem, that we're looking at addiction. We'll schedule an assessment. If somebody is IV drug user, pregnant, homeless, we consider that emergency, and we'll see that person immediately. A typical assessment right now is scheduled 2 weeks out for a non-emergency, and we have 5 people doing assessments right now, and there's just so many coming in right now that we've had to prioritize, the order we can put people in. So somebody comes in, they do their assessment. From the assessment, we can tell the level of care, the commitment the client's willing to make, and then we negotiate that together for what's going to be the best solution. Sometimes that'll involve an outpatient program. Sometimes it'll involve they might need to see somebody for detox, and then we have a physician's assistant on staff. So they'll go in and they'll see Mr. Tom Lumsden on a Thursday. He'll make the assessment of what's going to be the best route for detox. So say the person is alcohol. He'll probably say, I want you to go to a hospital because there's medical risk of dying during detox and, the health complications. Also with benzodiazepines, he may say hospital detox. If it's opiates or some other drug that he can prescribe medication, we'll do what they call an ambulatory detox.
Like a Vivitrol, are you talking about, or Suboxone?
Some medication, and it varies case by case what he prescribes. Typically, if he's doing an ambulatory detox, he'll follow the protocol for the appropriate medical, and I leave that to the medical team to make that call, and then the clinicians will support the level of care needed for that client to be successful. So sometimes if they have a safe, supportive family where they can stay with somebody who can hold the medication and give it to them once a day or once an hour or whatever the directions are, he'll have them stay with their family. Sometimes we'll take them into the house, detox them in the house on the medication. So case by case, we tailor. No 2 clients that come through the door have the same treatment. A lot of it is similar, the group therapy is the same, but what goes on individually or with medical or with mental health is tailored client by client for what their needs are. So once we can get the person clean and sober, early recovery enough to be able to participate in a group or individual sessions or a combination of the two, we begin an appropriate level of care. So somebody who needs, let's just say it's a man who comes in, he's using heroin IV, so he's an emergency assessment. We see him, do his assessment. We book him Thursday. Doc starts him on the detox. We get him clean and sober. We get him into the house. And then the sober housing that we have is partnered through Bianco Accommodations. We'll transport the clients back and forth. We'll get them to where they need to be for all their important commitments that they have in the community, whether it be court or whatnot. Mm-hmm. And we'll help them through that. So they start in the house. After a month in the house, they start to get extra privileges. Those privileges include having a phone, being able to have visitation, being able to have more freedom. And the longer they stay, the more freedom they get. By the time they're there 3 months, we start to look at, what do you want to do to get back on your feet? Maybe you have child support you need to get caught up on, or a driver's license reinstated, court costs to pay off, and we pay their rent for them while they're in treatment. So they're not having to worry about their financial woes, during this time. We'll work with the temp agency to get them on track, writing resumes, mock interviews, all of those sort of things. Once they secure some kind of employment, we'd like for them to go part-time in the beginning, just enough to cover what they need to survive on, and he can start working. He can have a car, additional freedom. We'll transfer him to a 3-day program instead of a 5-day program, and he can go morning or night, depending on what his job schedule is. And we encourage the guys to stay in the house for up to a year. The longer they stay, the more freedom they have, and eventually they'll be paying, rent at one of the other locations, which is very affordable and very supportive for their recovery.
Tim, going back for as far as, of course, LCADA's been here in Wadsworth. They're on Wadsworth Road, the old daycare center there, kind of at the entrance of the hospital out there. Right. Since what, August, or was it last fall?
August.
In August, I think we had the little ribbon cutting and everything out there. Now, for people that of course, this issue is, someone that wasn't involved yesterday or the day before could be needing these services now. For anybody that's listening, anybody that needs help, is that like for LCADA, a phone call from the family, from the addict to you, or is it through the courts or the legal system where they come to you for help?
There's a lot of routes people come to us from. Sometimes it's through we call it a carevention, which is like the TV show Intervention, where the family meets with one of our clinical staff, usually with our executive director or our CEO, which is Tom Stuber, and then he'll coordinate with the family and rehearse what they're going to do. They write their letters, they present the situation to their loved one, about how they see it's harming them and how they care about them. And then the offer to, there's treatment here for you, will you take this? And if the person has to agree, we can't force somebody to go. Right. And it's not effective if they're not willing to go. But usually the family can encourage them to the level of, if you're not going to go, you can't be part of our lives because you're killing us. And most of the time, they'll agree to go. If the carevention is done correctly and the family holds their, can hold their line, it's successful most of the time. So that would be one route. Another route would be somebody has an overdose and the EMS worker hands them one of our cards and says, I want you to do something about this because we might not be here next time with the Narcan. And a lot of time they'll call us individually after having an overdose or somebody close to them just died, some kind of crisis in their life that opens their eyes. And the key to getting somebody into treatment is while they're willing to go, get them engaged. The longer you wait, addicts have a short memory of consequences, and by the time they start using again, they're back on that hamster
again,
wheel,
right?
Or carousel, and round and round it starts all over again.
Well, let's talk about, you said that the men's house is now open and a women's house is soon opening.
Yes, that's also through Bianco Accommodations. It'll be a women-only program, and it'll be based on the same model that we have with the men's program. Up to 12 women can be in the house. We'll transport them back and forth for treatment 5 days a week. They'll meet with our physician's assistant or with our doctor, depending on what the scheduling is, and take care of their post-acute withdrawal symptoms and the other things and issues that they have medically. So they'll be transported back and forth for their therapy, and the same goes there. We want the people that make a commitment to doing a program to stay with us for a year. So it starts out intense, and detox is very intense. And then the day treatment part of it, which is a 5-day program, and then to a 3-day program, and then to individual sessions. From the time of the assessment until they go out with their own program of recovery, we want a year. The opiate recovery, the brain healing process, most of our clients don't come out of the fog until 30, 45 days. And like the whole idea of somebody like going to a 28-day treatment for heroin, they're going to die when they come out. Yeah, it's just not long enough. So,
Tim, normally we ask people who come in, how's business, how are things doing, and we always like to hear you're pretty popular. Kind of a two-edged sword when we ask you, are you very busy? Are there a lot of people taking advantage of what LCADA has, or are you not? Or people just deciding not to get treatment?
No, we have more business than, well, I wouldn't like to have that much business that we have, is really how it is. Nothing would make me happier than to have to go look for a different kind of job. Unfortunately, with the heroin and the opiates and the prescription abuse and whatnot that we're looking at, we're going to be looking at this for probably another 20 years. We haven't even hit the peak yet of the amount of people overdosing. Now, we've increased the amount of saves with the Dawn and the Narcan. That's absolutely incredible that the community's responded that way, because in the past, heroin always had that stigma of they did it to themselves and let them die, or that they get what they deserve and that kind of thing. And that's not the response that the community is having at all. It's what can we do to help this situation. I mean, when more people die of opiate overdose than do of car crashes, we really need to look at something.
Tina and I, we were discussing earlier this morning that the same trigger in someone's mind, that whether you're a diabetic or whatever, it makes you eat the donut, is the same trigger that makes a heroin user go to a drug. Now, the result is radically different. I mean, it could or couldn't be, but that same, even it's a dieter. I fell off my diet. That same human, thing. It's the same trigger. Yet somebody that comes in that lost 100 pounds or got the diabetic, whatever, they're a hero. They're this. They're that. Congratulations. But the addict that comes in and does that after 10 years, it's like there's still that stigma there that, well, yeah, you did it, but and unfortunately, the procuring cause there is the same in both situations. And so we were talking about that earlier, that it's when it's looked at differently. And I think a lot of the education that's been done here with the Drug Coalition and LCADA and everything else has helped that. And I think that the fact that your numbers are good here, with you being new here in town, I think that is a positive aspect, that the people want help. Wadsworth wanted this facility, and now we're using it.
Yes.
So, I mean, yeah, you don't want the numbers to be big, but the fact that the numbers are big, I think, does have a positive spin on it, too.
Yeah, I mean, ultimately, I'd like to see every single person who has his issues with addiction get help. The whole idea of, Americans are very self-sufficient, self-reliant, and stubborn, and that goes for addicts and not addicts. But it becomes dangerous when it gets to addiction, because a person can't get themselves out of the addiction. I was talking to our physician's assistant last night, and he made a statement to me, and he says, when I talk to the clients, I let them know, tell you what, here's the deal. I'll be responsible for your addiction, and you be responsible for your recovery. And he makes that bargain with patients as they come in. And I thought, that's a pretty good way to look at it. The client may not be responsible for their addiction because they certainly can't control it, or they already would have. Whereas the recovery part of it, that's the part where willpower comes in. And people say, oh, willpower has nothing to do with recovery. And I'm like, oh, yes, it does. It's up to the person that wants sobriety to go to the meetings, to go to the treatment, to take their medication, to make healthy choices, and coping skills, and all the other things that go with recovery. That is all willpower. That person has to want to do those things. Sometimes through the therapy that we do, we can bring people along through stages of change where at first maybe they're unsure what they can do or can't do. We support them and coach them through it, teach them skills that they can start using. Most addicts start using, it's a young people's kind of disease. They start using young. When I do an assessment, I'll ask somebody, how old were you the first time you drank alcohol or smoked marijuana or cocaine or whatever it was you did? And I'll hear a number like, 9th grade, 10th grade, and in that kind of age.
It's always those numbers that make you kind of squint your eyes a little bit. It's like, wow, yeah.
So you weren't on the track team, I guess.
Well,
some of them were.
Yeah. That's been one of the things that there. A few things. I don't think my brain has gotten past you saying that we haven't peaked yet You think this is going to be another 20-year-long battle. I could cry right now hearing that. Why is that? Why do you believe that?
Initially when I was in Lorain County at the time when the crisis hit there, and we noticed it there because the coroner said, "I'm out of my budget. I can't bury any more people. I've got twice the number of overdose than I've ever had." And then the next year it was double that, and then it was the prescription pills, and then when the policy started to clamp down on the pill mills and the overprescribing of the pain medications, addicts didn't get better because they didn't have pills from a pharmacy. They found it
elsewhere
with drug dealers, and the drug dealers would carry around a certain amount of pills and a certain amount of heroin, and one day they would go to buy their pills and they'd say, "Well, all I got is heroin, but it's cheaper," and it is. It's an 80 milligram pill might cost you $60, $70, $80, where 80 milligram of heroin doesn't.
And the problem is, as we learned at the forum, I mean, it's something I already knew too at the forum at the high school 2 nights ago, was that heroin's not what it was in the 70s. It's now laced with things that 1 grain of salt compared to 1 little piece of carfentanil that's coming in from China, from what I understand, can kill you. A grain of salt, that's all it takes of the carfentanil. And one of the feds said, it's not a matter of if you'll die, it's when.
Yeah, and the amazing thing is economics don't seem to be factoring in with this. In 1970, a bag of heroin was $10, and you had to inject it because the purity of it was so bad. You couldn't snort it, you couldn't smoke it. You would have to inject it to be able to use it.
Not anymore.
What's out now is $10 for a bag, and you can snort it, and there's a possibility there's enough in there that you could die from a $10 bag.
Oh, yeah. That's exactly what they were saying. Now, one of the other issues that Dr. Nicole Labor with SUMA said is there are enough beds available. The issue is health insurance companies aren't covering addiction.
When the Parity Act went through a couple years back, they started to say, mental health and behavioral health and, DSM-5, which is the Diagnostic Statistic Manual where you make diagnosis. And, it's considered as a disease. It got into that category where it needs to be covered. Not all insurances cover to an extent of what it needs to, though. When we enroll people on Medicaid, which is the majority of addicts who come in because they're not working, the addiction has just run roughshod over their whole life in every area, their family, their spiritual, their financial, their housing, their education, everything else has gone to the side except, heroin. We'll get them onto the CareSource provider, which is one of the best providers for insurance for addiction medicine.
It is 8:27 in the morning here, 97.1 Wadsworth Community Radio. In studio with us is Tim Smith, Clinical Director of Medina County's LCADA Way.
Tim, and I don't remember if these statistics are from Medina County or the city of Wadsworth, or that there are, when the police department or the EMS come, there are less people dying from overdoses, but there are more requests for aid for Narcan, and that is. How do you look at those numbers? Do you look at the fact that, well, we're losing less people, but still more people are trying, opiates in this case? Is just how do you look at that locally? Is that good news or just more bad news?
Well, I think the Narcan saves are an amazing thing. It's giving people a chance to get help, and it's bringing to their attention. In the past, they would have died. Traditional response to a 911 call. In the past, it had been, well, you have to wait for paramedics to get there, or you have to wait for somebody to have a Narcan kit to get there. The police are carrying them. The EMS are carrying them. We hired a retired firefighter from Akron to be our van driver, and he loves working with the guys. And I asked him, "Are you familiar with Narcan?" And he said, "Thousands of times."
Wow.
So I look at it as a good thing that people are getting saves. The alarming thing is how many saves are happening. If you look at the track record of, the reporting on it, Wadsworth alone had more deaths than the whole county did 10 years ago.
Right. Someone was just saying at the forum 2 nights ago at the high school that it took 6 Narcans to save his daughter, and she was 30 seconds away from being dead.
Yeah, it's the timing is the essence, is the quicker somebody can get and through the health department, families can get the Project Dawn, the Narcan kits, the nasal spray. Great Britain has gone to the it's like an EpiPen where it goes through the pants and you jab it right in the leg with a encased needle, but it pushes through when you jab. They've been dealing with the fentanyl and carfentanil a little longer than we have. That's a little new for us still, but they've had it much longer, and they found that the nasal is not making the saves. When somebody uses the nasal spray, those couple of seconds before EMS can get there with their full gear make the difference of somebody surviving an overdose.
Now, you were mentioning off air, too, that you have hired more help at LCADA Way, and after we talk about that, I want to turn the table a bit and talk about hope. There is hope. People do recover.
Yeah, and we're seeing, we've been in the county a little over a year, and we're starting to see people coming out on the recovery end of it, that they've finished their therapy. They're now active either in faith-based or 12-step or some kind of community support beyond treatment, where they've transitioned the skills they learned with us into their own life and adapted it. They're living happy, productive lives, having jobs, putting relationships back together. And when people try to look at only 1 in 20 or whatever the odds are, well, you're factoring in a lot of things when you're using those numbers. One of them is the majority of people won't seek help. The majority of people with an opiate addiction will die before they get help. So when you look at the numbers of who makes it successfully that tries, the numbers are very high. In fact, somebody that's determined 6 treatments within a 4-year span will be successful. And that's just a statistic for the nation.
Well, and the other thing too, the responsibility a little bit on I guess collectively our side of it is like saying the 28-day treatment, you're out. Part of that is realizing that the treatment that people are getting wasn't complete. So saying they failed, it's not they failed, it's like the system or the treatment failed them. It's like, okay, you go into the hospital and you break your arm or whatever. Well, okay, if they treat the break, but they don't treat the cut, you still get the infection. Sort of a roundabout way around that. But I mean, there's responsibility on you. You can't just say, oh, the addict, didn't recover or whatever. Well, there's some responsibility on the treatment side of that we've all learned and through the education have been able to address those issues.
Yeah, the vast majority of evidence-based practice, the tool that we use, at LCADA we use the Matrix, and we also use Living in Balance. Those 2 programs were initially developed as a cocaine treatment program. It's a much shorter, but what we've been able to do is they've come out with some additional units to add to it, to where we can adapt the same thing we're familiar with for dealing with things like cocaine and stimulants, which was the 80s and the 90s and the early 2000s, which was crack. Now that we're looking at heroin, the treatment needs to be longer, the cravings are more intense, and the triggers that you were talking about, somebody with a jelly donut, when a heroin addict has a trigger, and the trigger could be something that's an open trigger, everybody can see it, they see their drug dealer. Their significant other is using in the house with them, and they're trying not to use, they're going to struggle. Those are open triggers. What we look for, the hidden triggers. So it's an anniversary of a death of your grandmother. It's relationships. It's stress. And, when it comes back to the old halt, hungry, angry, lonely, tired, those are very valid things. And you don't want to have an addict being any one of those things for too long. Unfortunately, when a 14-year-old starts smoking pot, they quit coping. Now we're looking at this person and they're 23 years old and they have the same skills that they had when they were 14 for coping. If they don't have something to cope with, they're going to be triggered and they're going to use.
Well, and that's part of that 20 years before you see the numbers come down, because that goes back, I'm assuming, a lot to education starting at 5, 6, 7, 8 years old with that. So that's part of the longevity in those numbers, is we have to start at that basic level. Unfortunately, 14, 15 years old, you think you're starting there, but statistics show they're using already. So that's a different treatment area than the prevention at 5, 6, 7, 8 years old.
Well, that's the next topic I wanted to mention. Is I think that I have 2 young boys. Young is in 3 and 8 months old. I, like many others, are saying, what are the prevention options? What do you do at 7 years old to start the talk about drugs? And I think that's what a lot of people are trying to figure out. We now know that we have to start the prevention and the talk sooner, but how do you do that? And I've said from the beginning, too, I saw it with my own family members who were addicted. They lacked the coping skills. So if someone is listening right now, maybe on the younger age spectrum, can you talk about some coping skills? Do you have any ways to start a conversation with a young child? It's something I'm grasping.
Yeah, I
for
think
this.
it all starts with the relationship and the communication style that the family uses. If parents have dinner at the dinner table and they talk during their dinner, there's a real good chance that you're going to know what's going on with everybody in your family. Those coping skills of learning how to talk to somebody who cares about what you're saying are critical for a young person. The kids also need a little bit more than just a supportive family, though. During 98, 99, 2000, I worked with a program it was based on What Kids Need to Succeed by Dr. Peter Benson. It was a prevention program, and what he was looking at were internal and external assets that kids can possess. And it turns out that 20 of these internal assets develop as a result of these 20 external. So some of those things would be, and it could be any combination of any of these things. It would be, there's another adult outside my family that cares whether I live or die, and the kids believe that. There's a teacher, there's a coach, there's a mentor, there's somebody outside, there's some kind of participation in faith-based. There's open communication within the family. There's creative outlets. There's exercise and physical outlets that they have available, that the kids have a sense of people care about me. Those things are created. They start with the nurturing family from the time they're born, but if it doesn't transfer into the community, they don't internalize any of those things, and they feel alone and isolated and cut off. And if you listen to an addict talk about it, they'll always say, I always felt like a square peg in a round hole. Like I just never felt like I belonged. I kept thinking one day the UFO will come down and take me back to the planet where I was born. And, they have that sense of disconnect with their community and family, sense of isolation. And unfortunately, in early recovery, addicts want to do 2 things that are big mistakes. One is, I want to treat my loneliness with isolation, and the other one is I want to treat my anger with rage and violence, or inappropriate language, or some other kind of lashing out. It's not always physical.
Tim, can recovering addicts or folks who have recovered for a while, are they a help? Can they help folks who may be newly into detox and that? Can they be a help, or I don't want to say not a role model, but something that people can look at and says, well, if he can do it, I can do it, or something like that?
Yeah, there's a lot of that in the recovery community. If all of the 12 steps are based on there's somebody that's got success and time. With the problem that this other person has, and then they pair up. One person becomes the sponsor, one person is the sponsoree or an AA sponsee, and that person's a mentor for them in recovery. And they see how this person handles situations and what they do. They go to meetings, they go to detoxes, they go to jails. They're supportive of people in early recovery, letting them know, here's what you should do, here's what you shouldn't do. Don't get in a new relationship. Don't make any major decisions. Have some spiritual growth. And all of them have a literature base that they use of some sort. Either it's Alcoholics Anonymous Big Book or Narcotics Anonymous Basic Text. And, there's a uniformity to this is how we do what we do. And if people adapt those things, which, by the way, those 12 steps were all stolen from the church, you can find them there. But it's harder to find them if you don't know what you're looking for there.
Right, yeah, exactly.
Well, Tim, thank you so much for joining us and educating us and for doing all that you do with the LCADA Way. You are saving lives, you are changing lives, and no doubt from what I understand and have experienced with my own family members, and as you know, recovery takes effort every single day, but it can be done.
Yeah, it takes a lot. It takes the whole family, the whole community to help them do it, too.